Welcome, everyone, and thank you for joining us for this evening's MedTech Color webinar on cardiometabolic health. We are here this evening to shine a light on where medicine can do better, to understand how cardiometabolic risk shows up differently across different patient populations, and to explore solutions that close the gaps on these differences through earlier diagnoses, more inclusive care, and innovative approaches. Cardiometabolic disease is the intersection of cardiovascular, kidney, and metabolic disorders, and is a leading driver of morbidity and mortality in the United States. But what's equally urgent is that that burden is not shared equally. Communities of color and other underrepresented populations experience higher rates, more severe disease, and too often poorer outcomes. Cardiometabolic disease isn't just about the heart or diabetes in isolation. It's a complex web that affects multiple organ systems, impacts quality of life, and drives disparities in outcomes. So that's why this evening we are fortunate to have a distinguished panel who bring unique insights from across the care continuum. Doctors Roy Matthew, Pierre Theodore, and Patrick G. Gentlemen, if you would, be so kind as to introduce yourselves. Dr. Matthew?
Yes, hi, Dr. Sparks and the whole MedTech Color team and Reverend Miles and the congregation. Really an honor to be here today to discuss a topic that's near and dear to my heart, and I'm sure to many others as well. I'm a nephrologist, a kidney specialist at Loma Linda University in Southern California. It's in San Bernardino County, which is one of the largest counties in California. I've had a almost 20-year history, primarily working in the VA health system, but have seen the breadth of various kidney diseases across the spectrum, primarily in the adult population. And I also have a specific research focus on the intersection between cardiovascular and kidney disease, which is why I've had the opportunity to work very closely with the development of the concept of the cardio-kidney metabolic syndrome along with Dr. G. And so really excited to be here to talk with everyone today. Thank you.
Thank you.
Dr. Theodore?
Thanks so much, Dr. Sparks and Reverend Miles. What an honor it is to be here to join you today and echo the same sentiment of thanks. And my name is Pierre Theodore, and by way of background, I'm trained as a cardiothoracic surgeon and was on practice and on the faculty at the University of California at San Francisco for many years, and then began to evolve my practice beyond just doing robotic and cardiovascular and thoracic surgery at UCSF, and became very interested in global surgery. I was doing surgery in low and middle income environments. My family is from Haiti. When I did more of surgery outside of the United States in low income environments, I realized that many of the structures and the barriers that patients were facing to care, even in low income settings, were very similar to some of the same barriers that I was seeing closer to home in urban settings and in rural settings and the like, even here in the US. And it started to change my approach to how I thought about healthcare and healthcare delivery. So I took on a couple of roles in research and development in big pharma companies, and I now work at the pharma giant Roche Pharmaceuticals out of Basel, Switzerland. And I focus on really some of the population health and the barriers to care, specifically in cardiometabolic diseases, and really delighted to discuss this topic with all of you today.
Thank you.
Thank you.
And Dr. G?
Thank you, Dr. Sparks, and thank you, Reverend Miles. My name is Patrick G. Currently reside in Richmond, Virginia. I am a healthcare consultant and global patient advocate, currently living with diabetic kidney disease and also post-kidney transplant for about 8.5 years. I have a faith-based nonprofit called I Advocate, which is a health and wellness organization where I merge faith and health literacy, really focusing on underserved, undervalued, and disenfranchised communities of color. My lived experience really engulfs everything that we're going to talk about. So for folks in the audience that are kind of like myself, still trying to figure out how to maneuver all of the things that we're going to talk about tonight. I certainly not only invite you to be engaged in this discussion, but to really take some really good notes. So thank you very much.
Well, thank you. Let's dive right in. Which one of you would like to tell me what is cardiometabolic health and why are the consequences often harsher in underrepresented communities? I open that up to the panel.
Yeah, look, well, maybe I'll just kick off to start us off and kind of get the conversation rolling. Sometimes that term metabolic health is not a particularly clear one, but it suggests how the human body uses the energy that we take in through food effectively to engage in all the bodily processes that we have to go through every day of our lives. And when there is excess amounts of food coming in, the body has to figure out some way to manage that. Manages that with fat accumulation, and often the onset of the condition of diabetes, which we'll touch on, which is a mismanagement of excess blood glucose or sugar as a result of the diet. And the consequence of what we call a metabolic derangement, which is really that mismanagement of the calories that are being taken in from food, creates a chronic, long-standing inflammatory condition. And so it's not sometimes just a matter of not eating this or not eating that, but understanding that there is this persistent, durable inflammatory condition that sets in. And that results in things like weight loss, but weight gain, but more importantly, there are downstream effects to all of the organs that you can name. So cardiac disease, renal disease, hepatic disease, eye disease, skin disease, and so forth. And so this issue of metabolic derangement, that is, how do we manage the calories that we take in effectively, can ultimately impact every possible organ. So cardiac disease and coronary disease, or renal disease and renal failure, as we'll talk about by Dr. Gee, Dr. Matthew. And the important point here is that as a consequence of that, what we call metabolic disarray, mismanaging that calorie intake, we have all of these downstream effects on multiple organ systems. Maybe I'll turn it over to you, Dr. Matthew.
Yeah, no, that was phenomenal. I mean, I think that just as a piggyback, and I know Dr. Shi will touch upon this as well. We was really fortunate to have some time where we had a lot of time to talk with patients about this concept, and I think that was one of the biggest surprises actually to myself and my colleague who's a cardiologist who were in this panel. Was we just started talking about this concept of metabolic syndrome because it was just, we wanted to sort of connect it with the organ dysfunction, which has been sort of one of the deficiencies, I think, in our medical terminology. And thank you for highlighting that. And as we talked about this, one of the things that really we started to understand that came out was this lack of understanding. What do you mean by metabolic syndrome? And really what was so surprising was, I think we just, as medical professionals, we just took it for granted. I mean, we sort of just started to understand it, or maybe we just, kind of knew what the pieces were, like you mentioned, and we just sort of put it together in our heads and we just worked with it because we just kind of got the sense of what that patient looked like. But we realized as we were talking that we never really translated that. And I think you put it beautifully the way you talked about all the different components of food, metabolism, and then the organ effects. And I think that's now the big step that we're now trying to take. And we've been helped by, I think, a lot of the drugs that are really effective nowadays. But not even just thinking about that, they've just sort of been the vehicle for us to understand that there's a concrete way that we need to talk about this, especially with patients, which is that this is not just some random thing of, being bigger or being smaller. We're really affecting these organs. And like you mentioned, it's just everything. The cardiometabolic definitely is focused on the heart, and now we're realizing that it's just really affecting everything. And like you said, the liver, I think, is another big one. Is we're seeing so much cirrhosis just from these metabolic disorders, the sleep apneas, as you mentioned, and the kidney failure in my own realm is, and Dr. G can talk about as well. So yeah, I think that's, that component of really bringing in the consequence of the organs. I think that's really where we're really sort of opening the eyes of everyone. So Dr. G, I think I'll turn that back to you now.
Yeah, now from the patient perspective, it was really interesting joining Dr. Matthew and the, other peers with the American Heart Association, CKMH patient advisory group, and learning about this. Then I go back to my health team and I'm like, hey, how come nobody ever explained this to me? And they couldn't explain it.
Mhm.
So it was really interesting because I'm asking them to talk about something that was never discussed. Mind you, I grew up in the projects in Richmond, and I never heard about diabetes. And it was sad that I didn't get diagnosed with diabetes until I'm in my 40s, and then renal failure in my 50s. And this is almost like a common occurrence with minoritized groups.
Mm-hmm.
We don't have these talks that are necessary. And I really appreciate the discussion around nutrition and what we eat, because it brings up the question, how do people manage cardio kidney metabolic health if they live in a food apartheid, if they live in areas that have been, really, a lot of folks talk about social determinants of health, but nobody talks about environmental, political, financial, technology, and all these other determinants that really play a big part in all of these things, especially diabetes and obesity. And it's for a lot of my advocate friends, we found that joining these particular organizations and actually learning about this firsthand allows us to be able to go and talk to fellow patients, just to be able to encourage them, hey, look, we're not physicians, but this is what we receive. Take this patient-facing information and please go talk to your doctor. Just because you have kidney disease but don't have diabetes doesn't mean that it can't affect you from, other comorbid conditions. So I am really appreciating this discussion so far, because a lot of folks, even those that are probably in attendance here, probably haven't heard of these things, may not have all of the comorbid conditions, but yet and still they are all at risk for being able to get this due to the metabolic implication. So really appreciate this.
I'd like to add
Yeah.
right there, we have an opportunity for the audience to put their questions in a chat, because you're hearing from someone that said he was diagnosed late because maybe he didn't know what the right questions were to ask, or he didn't know what the right expectation was when he saw his physician. So if you have questions as we continue this discussion, we invite you to put them in the chat so that at the end, toward the end of our hour here, we will address those for you. But what I'd like to ask Dr. Matthew, what are some of the things that help people to be alerted that they may have a metabolic dysfunction?
Yeah, that's a great question. So I think the first thing, obviously, is your general vital signs. When you go to see your physician, looking at your weight, looking at your blood pressure, are the two simplest things that sort of give you the earliest indication of what it is. Now, the concept of weight is really very complicated, and I want to really be careful about this, because I think we have to be careful about turning a medical concept into sort of this social stigma, right? And that constantly happens. And weight is really very, very different for many different populations. And so we have known this, yet we've, sort of been pigeonholed into this, singular concept of BMI, what is right and what is wrong, based on a very probably limited population estimate. And um, I think we're starting to grow about beyond that now, and started to think of more sophisticated ways of thinking about body composition, and rather than just weight, thinking of things like waist circumference, and maybe even other things like the bioimpedance, looking at body distribution. I think those are other things that can also help better qualify what our physiologic, our body parameters should look like. Then, what are the other things that start to go into this metabolic component? Those are the things that I think, Dr. Theodore had mentioned previously, the routine things that you're going to be checking for when you go see your physician or provider, whoever they may be. Checking your cholesterol once every, 2 to 3 years in your earlier ages, or annually as you start getting older. Checking an A1C at least once in your early stages. And we can't forget that a lot of these start to show up in your early 20s, and even into your early 30s. These are the times when we can really get a good hold of it. So getting these early checkups in our young adulthood, when we can really make a difference for our later selves, is really important. And then, the other thing that we're really starting to push as a marker of endothelial, so our blood vessels throughout our body, and metabolic health, is looking at the urine for albumin to creatinine ratio, or urine albuminuria. And we really want to emphasize that it's not just for kidney disease, it's actually a marker of cardiovascular health. And so the lower ranges, we might start seeing it, and especially in the minority communities, we are seeing this albuminuria, that we call it, earlier, and it may be an earlier indicator that we need to be more intensified in our preventive measures. So those are really the simple metrics that you can get with any of your healthcare providers if you go in for even a periodic health check, and you should really be asking for those things. Can you check my waist circumference? Am I in a good parameter? Can you check my cholesterol? Can you check my A1C at least once if you're young and you don't have diabetes? And can I get a urine albumin to creatinine ratio checked?
Great. Dr. Theodore, you as a surgeon, how do these cardiometabolic or these metabolic disorders affect what you do in people receiving care or considering elective surgery or needing urgent surgery?
Yeah, it's a great question, Dr. Sparks. And before diving into that, I do want to make a comment just to add on to what Dr. Matthews said, because so important. And sometimes it's almost, you can almost think about as a game, in that if you close your eyes, you should have a sense for what your systolic blood pressure and your diastolic blood pressures are. Like, those numbers should be in your mind. And if they're not, that's not a problem immediately, but it means that you need to get into a primary care doctor where you have a sense. If someone asks you on the street, tell me what your blood pressure is, you could give an immediate answer. And the other one I think often gets overlooked is knowing what a fasting blood glucose level looks like, which is basically, if you haven't eaten for 10 hours or so, what does your glucose level look like, particularly in the morning? Because that's a really easy overall predictor of prediabetes and the risk for going on for progressive disease. And if we've thrown at you a whole bunch of parameters, it may be a little hard to figure out, which is a critical, which do I remember. There's actually a calculator that's online through the American Heart Association. It's called the Prevent Online Calculator of Heart Disease, and has all those parameters there. And if you don't know them, you can even take the calculator with you to a primary care doctor and say, I need to fill this in, so you have a real sense of your risk of cardiac disease in specific, but really end organ disease, generally speaking. So I just wanted to echo Dr. Matthews' excellent points, and then provide that practical clue about how to really know what those parameters may be. You asked a great question about surgery. You know, you can think about surgery in a sense as being like an athletic event in which all of a sudden, whether it's emergency or it's elective, that essentially what's being asked of you is to go through something that's physically demanding in the operating room with the surgeon. And so if there is metabolic disarray or metabolic challenges, that can make the surgery all the more difficult. Just like if you had never gotten off your couch and then someone came to you and said, let's run 200 meters as fast as we could, you might be huffing and puffing at the end of those 200 meters. So it's the same kind of idea, is to make sure our metabolic health is well maintained in the event that there's an urgent surgery that's ever needed. And in the event that there's an elective surgery that's ever needed, we were talking earlier about sometimes needing to get blood glucose under control, certainly getting blood pressure under control going into surgery, so that the risk of that operation goes down. Because the one thing we do see is that the risk of surgery almost across the board goes up in minoritized populations.
Hmm.
And it's not a consequence of the color of my skin, it's a consequence of comorbid diseases not being well managed prior to surgery. So I think the question is an important one, and it reminds us again that the metabolic disease can be important for the long-term organ function or your ability to respond in the short term to a stress like surgery or another trauma. So thanks for that question.
And Dr. Theodore, just to follow up on that, are you worried about the surgery, the anesthesia, or the healing afterwards, or is it all of it?
Yeah, by far the most important thing is the healing afterwards. We know that diabetes is associated with a higher risk of wound infections, and if you need a hip replacement or a knee replacement, the concern that that implant could be infected becomes pretty severe in patients that have poorly controlled diabetes. We know that patients that don't have very good metabolic condition are slow to get up and walk after surgery. So in some ways, again, think about it almost like an athletic contest that you're constantly preparing for, so that when the time does come, and hopefully it doesn't, that you need a surgical intervention, the body and the mind are both prepared for that.
Yeah, I know in many of my interactions with my surgical colleagues, dealing with my patient population, which of course is one of those end consequences of the metabolic conditions. That's one of the big challenges I face, because just having that lower kidney function puts at such high risk. And simple things, not simple things, but I mean, a lot of the elective surgeries that really affect quality of life, like, knee replacements and hip replacements, because it just really limits sort of the compounds that metabolic problem. You have so much pain, you can't move. But you need to move to limit the metabolic conditions. Um, and just having that low kidney function puts them at higher risk for those failures, and that becomes harder to fix once that's already established. So really, this is why it's so important, I think, to get people to know about these things early, because we can't do much once the creatinine's already high and the kidney function is low. You guys are limited, and I can't convince you guys, to take that risk to, potentially hurt the patient in other ways when you're trying to help them in another way. So yeah, thank you.
Well put.
Dr. G, hearing from the medical side, all of the consequence, what do you as a patient advocate do to encourage people to ask different kinds of questions? Or where do they find the courage? How do they have the courage to actually get in there and advocate for themselves on these issues?
One of the things that folks can do is certainly join patient organizations where they kind of have mentorship programs, peer mentors that will kind of help you to be emboldened and in asking the questions. Also, working with certain organizations, again, like the American Heart Association, for me, the American Society of Nephrology, the American Diabetes Association, sitting there in the room with medical professionals as they talk about this, certainly taking notes, making sure that they get information and share it with the community. That's one of the biggest things. And even when we talk to physician groups, they know a lot of times that patient advocates are able to translate certain health literacy in plain language summary. So it's normally like the meeting after the meeting. Let's say, for instance, I had an appointment with Dr. Theodore prepping for surgery. And he says some stuff because I'm working with these organizations, I'm able to interpret it. But when I get home and a friend of mine's called and was like, hey, G, was it a good visit or a bad visit? I can simplify the information. But one of the things that's really hurting our community is that, we are still dealing with a number of communities that don't have access to health literacy. They don't have access to a lot of the new medical innovations that are currently helping us now to be able to manage our current disease states. Again, food is an issue. I know there have been a number of food as medicine programs that have lost funding. So it is really hard, and sometimes you really have to really work together and collaborate, kind of like how Enon is doing, with the health fairs and stuff like that, really engaging with the community and building trust to where now folks in the community, where we certainly understand about clinical research and the negative connotation about people of color in clinical trials. But now when you see all of the things that Enon is doing for the community, because they have a footprint in the community, now they've given not only the parishioners, but other folks in that community a safe haven. They've emboldened them to be able to go to their physicians and say, hey, this is what I've learned. You keep telling me that I have this, this, and this. This is the test that I want to be done. Because like I said before, hadn't heard the term diabetes until I was diagnosed with diabetes. So even though that was some years ago, we still have a long way to go because there are still underrepresented rural communities that medical providers, even pharmaceutical companies aren't willing to go to. And these are the folks that really need this information so that they will at least have a fighting chance to be able to speak up for themselves and for others.
Well, thank you for that. And at the end, I'm going to ask each of you to think about, so I'm going to give you a little time just to think about what's one question. If you had a patient at risk, what's one question when they saw you wish they would ask you so that you can open that door for that dialogue? But as we sit right now, we've heard about the consequence of metabolic disorders, the intersection of cardiovascular health and kidney or renal health. But let's talk about some of the positive things. What are some of the new things on the horizon that have come to fruition that after this discussion, if people, get engaged and interact with their providers, that they can expect and how and what expectation can they have for improvement of these disorders?
Um, uh, you know what? I would like to start this off just by talking about what I had to overcome. So just a bit about my story. So in 2003, feeling fatigue, working 20 hours a day, sleeping 3.5, shower, eating all 3 meals at one time, going to sleep. It was just really crazy. Um, I go to a nurse at work and, I'm telling her that I'm really feeling tired and all this other stuff. She checks my glucose level. And, right there, my glucose is 748. So I should be dead. I mean, I should either, have had a stroke, heart attack, or something. Immediately, I have an officer to take me to the emergency room where my A1C is 11.7. Now, mind you, this whole time, going from elementary, middle, high school, even college, never one time in a health class did I learn anything about diabetes.
Mm-hmm.
But Dr. G, can I interrupt for just a second?
Yes, ma'am.
You threw out some numbers. Are those numbers big numbers? Or are they small numbers? What should the number be? I mean, so some people may think 748, the bigger the better. What do you say to that?
Like I said, I should have been dead. 748, we are eulogizing the person and putting them in the ground.
Okay.
For me, and I would even defer to the physicians, I know what I've been told, my glucose level, if it exceeds 180 on a fast, I'm in trouble. Now, I can see if this is like an hour after I eat and it gets elevated and it's going to come down. But if I'm on a 10-hour fast and I take my glucose level and it is 180, this is beyond pre-diabetes. I'm full-blown type 2 diabetic. And then with type 1s, it's totally different. My A1C at 11.7, where it should have been between 4.4 and 5.9, I believe. And that's because I get fussed at by my diabetologist to make sure my numbers are right there. So of course I was a hot mess because I didn't know any better. And being referred to an endocrinologist, and she treated me for 10 years and not telling me that diabetes is the #1 leading cause of kidney disease, but she gives me 2 insulins, 2 different types of insulin, puts me on a pill medication, and just said, Patrick, you need to lose weight. And that's it. No nutritional guide, nothing else. And then in April of 2013, while I just finished up an appointment with her, I'm getting ready to get in my vehicle. She runs out the office. Patrick, I forgot to tell you that you're at stage 3B of end-stage kidney disease, and you only have between 30 to 35% kidney function. I did not know what she was talking about. If somebody would have put a gun to my head and said, hey, put your hands on your kidneys, I could not tell you, to be perfectly honest. So that left me in shock because I didn't know if I was dying. Nobody asked me if I wanted to talk to a counselor, a therapist, or anybody, but they referred me to a nephrologist, a kidney doctor, for those that don't know. The nephrologist was like, well, Patrick, you're going to eventually go on dialysis. Again, I didn't know what dialysis was, but we can slow down the progression by abstaining from nut products, dairy products, and chocolate. And eventually, as time went on, I started picking up weight because my kidneys wasn't putting out the amount of urine that it was supposed. So November of 2013, I have blown up from 210 pounds to like 300, probably about 375. I can't lay down and sleep after sitting up in a chair. And at that particular time, I made the decision to go ahead and have the surgery to do peritoneal dialysis. After a few weeks of healing, December the 1st, 2013 was when I did the very first exchange of peritoneal dialysis. I do dialysis for a while up until April the 21st, April the 21st, 2017, when I get a kidney transplant. Because of what Dr. Theodore and Dr. Matthew talked about in making sure you have your numbers maintained. Now I'm dealing with delayed graft function. The new kidney isn't working. So now I have to do 24 hours of bedside dialysis every other day. 5 days after the surgery or the transplant, I had a blood clot in my neck, I had to have a surgery. 3 days after the blood clot surgery, I was hemorrhaging, had to have another surgery. 17 days later, they created what was known as a laparoscopic peritoneal window so I could drain internally. 4 surgeries, 33 days in the hospital, 6 days doing physical occupational rehab. I finally go home. My kidney wakes up on the 47th day. And when I said wake up, I was in complete stage 5, had urinated for 2.5 years. The first drop of urine that came out. And it made me realize that what I did not know, I had to take control of it. I had to start really having a deep discussion with my physicians on what are the new therapies that are out there. One, I had to make nutritional lifestyle changes. So I enrolled in a weight loss clinic. I lost between 95 to 100 pounds. Just going to the gym, changing how I ate, changing how I exercised, how I slept, and of course, reducing stress. Then I was introduced to GLP-1s that would help me not only manage my diabetes, manage my weight loss, but they also have indicators for protection of the heart, protection of the kidneys. Then we now
Dr.
have.
Let me interrupt you just one
Yes,
second.
ma'am.
You used a term that I'd love the physicians to talk about,
Yes, ma'am.
GLP-1s. And that's kind of a buzzword these days. And
Right.
so the celebrities are getting skinny. Can everybody get skinny? And is that a good thing? Dr. Theodore, what about you? Because they have an effect on surgical candidates as well, these GLP-1s.
Mhm.
Yeah, first thing I just want to, listening Dr. Gee speak about his experience is that, I mean, it's really remarkable, right? To think about a delay in diagnosis and then perhaps suboptimal management and ultimately requiring transplantation. And it really does speak, I think one of the important things we can leave as a take-home message, the importance of kind of knowing your numbers. And you mentioned earlier about advocacy and having people that can ask the right questions and sometimes uncomfortable questions of your physicians. Like, I want to know what my fasting glucose level is. I want to have it written down. I want to really be on top of the data that determines my risk for disease. So I want to start off by acknowledging that, acknowledging what you went through, and also that you've come a long way from where you once were, for sure. That is the case. And also, it also speaks to me as I hear that story, how far we have come as a profession as well in managing metabolic disarray, type 2 diabetes, hyperglycemia. And you mentioned one of the drugs, the GLP-1s, that get directly to your questions. And GLP-1, and that's, I'll just use the generic term, or the term you'll often hear applied is Ozempic type medications, because that's probably the trade name that's most associated with this class of drugs, are a drug that can be given in a couple of ways, either orally or with a subcutaneous injection, often weekly, although we're working on prolonging that period of dosing, that effectively help the pancreas do its job a little bit better by driving down the blood glucose levels. So helping to reduce the severity of diabetes. And it has this also additional effect of significant amounts of weight loss over time. So not only does it potentiate insulin and make the pancreas more effective, but it also tends to prevent people from eating as much, their weight drops, and so as a result, their diabetes overall improves. And this category of medications in many ways has revolutionized the treatment of type 2 diabetes. So much so that some of my colleagues at some of the major healthcare systems say, if you have type 2 diabetes, you should be on some form of one of these additional medical therapies to help assist with the effect of the insulin as well, because there's no reason not to try to drive weight down so that the diabetes improves. So maybe, Dr. Matthew, I can turn it over to you as a medical practitioner to fill in the blanks there that a surgeon offered.
No, that's, I think you addressed all of it. I mean, I think that's, it is really a very exciting new area. Um, you know, I think that you're exactly right. I mean, the weight loss effects really just sort of were the icing on the cake. It really is a very complex, and now we have a lot of newer drugs that are targeting more of these hormones and the pathways that may or may not be, probably will be additionally better, additional benefits to that. But, really the exciting thing that we saw was that even if you're not diabetic, but if you do have a lot of these metabolic components primarily reflected in overweight or obese, there's additional benefits on your heart and kidney benefit as well. So there's a lot of excitement around these new drugs. Yeah.
That's right.
Are there newer tools, even on the internet or anything, that people can track their metabolic health in? I mean, or do we suggest that? Are there opportunities to become more engaged? So people may get to see their physician, because now the waiting time to actually get into an appointment is so long. Are there tools that patients can employ in between those visits to ensure, number one, that they're prepared when they go to the appointment should something be awry, or should they not understand something? Because it's bad to not know what you don't know, right? And so what are your experiences with guidance for patients in this area?
Therese, let me jump in here because I think there is a tool that's becoming increasingly used both in sort of the medical settings that is prescribed by a physician, but also is now increasingly available to consumers that is over the counter. And these are known as CGMs, or continuous glucose monitors. They're basically, sometimes when you think about a diabetic, you think of someone pricking their finger and taking one drop of blood and then testing that drop of blood in a sensor. And effectively, a continuous glucose monitor allows a small patch that's placed on the skin with a tiny filament that goes through the skin to continuously monitor and measure glucose levels. And it can give really tight information about, I think what Dr. Gia mentioned earlier, about the resting glucose level or fasting glucose levels in the morning, your postprandial, that is, and it can create even graphs from software that you can share with your physician. So for people that are asking themselves, do I need to better monitor my blood sugars? What can I learn about my own metabolic health? I actually think that continuous glucose monitors can be very important tools. I'd love to hear from the rest of our panelists if they've had experience or opinions on the matter.
Yeah, I just went on one a couple of months ago after going to the American Diabetes conference. And one of the unique things about it is that all of my care team now they can actually read in real time my numbers. So in real time, it will give me my A1C. In real time, they can read my glucose level. In real time, they will find out what I ate: breakfast, lunch, dinner, snacks, exercise, any other things that I decide to put in the little comment section. And all of my physicians can actually read and actually keep up. So when we go for a visit, we're just basically like talking about my management over 7 days, 30 days, 60, 90, a year. And you can really see it'll also show you a graph to where you can see your progress. And we can certainly sit there and say, hey, what happened on this particular day? You might want to cut back on this. You might want to do this type of exercise. It has really been a blessing and a really useful tool.
Is it accessible? Can anybody get one?
Yeah, I think so.
Well,
I think
the one that I use is a Libre, and you need a prescription, but there are some that you can get over the counter.
That's right. That's exactly right. There are multiples types and brands that are now available over the counter. But to your point, I think it's also important that a conversation with a physician can result in a prescription, even for patients sometimes with prediabetes who are at high risk. So it's something that's worth considering. And I'm also going to put in the chat for all that may be on the line. There's an app called the My Sugar app, which allows you to integrate information from any device, and also gives a lot of information around, diet, what to eat and not to eat, when to eat and not to eat, and even exercise and what have you. So there's a lot of information we can draw from to help to mitigate the risk. And I think that's what we're learning. I think hearing Dr. Gee's kind of story reminds us of what can be done to lower the risk of that end organ damage that we're talking about today: kidney failure, heart disease.
Yeah, and
Okay,
of
we're
course
kind of coming to the, oh, I'm sorry, go ahead,
oh
Dr.
no, I was just
Matthew.
going to say the traditional stuff like blood pressure and weight are always, very good parameters to know. We have always been, sort of rigid about loving the upper arm cuff. There, but I do acknowledge there's a lot of devices that are coming out there that are really simplifying blood pressure measurements, and I think we will start to approve those. Even the most recent AHA hypertension guidelines acknowledge that they're out there, and that we will eventually start having more data on there. I think that if you are going to measure your blood pressure, if you do decide to use something a little bit easier like a wrist cuff or even one of the devices on your phone, just check it with your providers, see if you are getting sort of similar readings. And if you are, then be regular with it. Again, the American Heart Association website has really nice diagrams about how you should take blood pressure. So the other thing is to learn how to do a good blood pressure measurement. That is one of the things that has really become what in hindsight, what we've known has been one of the bigger problems with blood pressure is just that it's been so variedly measured. Even in your clinic, I'm sure many patients are known, they're rushed in by their provider, by the nurses and the techs, and then they quickly get their blood pressure, and then the provider comes in and see them, and then you wonder why every time you go into you see your provider, your blood pressure is 190 over 100, and then at home you're like, I feel fine, and nothing happens. And so I think we've realized that these home readings are critical, and it really adds value. And the other nice thing about blood pressure is that we don't need it every minute of the day. Unlike sugar, you can measure it 2 or 3 times a week, and it's the average over time, just with those few values, is just as valuable and also predictive of what's going to happen to you down the line. And we can really be careful with medications as well if you really get a good sense of what your blood pressure at home is. So I just wanted to quickly just add that as well.
I think that's all excellent advice. And I think the thing that I hope that the audience really gets out of this is we are encouraging you to be proactive in your own care. And so these are things that now your providers have an expectation that you'll ask. Dr. Theodore once said, make them uncomfortable. If that's what it takes, make them uncomfortable. But it's up to you to do that. And what I hope we've done tonight is to give you some opportunities to take a look, first of all, personally at your own health status and decide what's important to you about that health status. And then the next thing, do you have a resource that you can go to and say, I have a question about this? And the last one is, are you actually plugged into the healthcare system? And if you're not, let's understand why you're not. But this is just one aspect. This is just one disease state that we need to be talking about to help get you motivated to be an advocate for yourself. And so at the top of the hour, we have about 10 minutes left. I told each of you, I'd just like for your one action step. What is the one thing that you want your patients to either know, do, or ask?
So I'll jump in here just to maybe kick off. I think it's a great question because it also forces us to focus on something that someone can take with them after our conversation is done. And maybe I'm repeating myself, but I would say to quote, know your numbers. And I think there's 3 that really come to mind. The first is to know your blood pressure. The second is to have a sense of your fasting glucose level, which will put you in the category of normal, pre-diabetic, or possibly, as we talked about before, frank type 2 diabetes, and that picked up by that simple question of your fasting glucose as a screening test. There are other better tests, but it's a good way to screen. And the third is to know total cholesterol level.
Mm.
And while there are many other sensitive tests that can be done, those three numbers take you a long way in understanding and then ultimately responding to your risk of cardiac disease and of kidney disease that we're talking about today. So I would leave the audience with the idea of knowing your numbers.
Yeah, that's exactly right. And I would also add that you know, oftentimes we're going to identify a problem when we see many of our patients, and especially when they come to a specialist. There's probably a problem that needs to be managed as well. Um, we're very quick to prescribe a lot of things, and now we're really especially sort of encouraged to prescribe a lot of things. And I always encourage patients, and I really actually am appreciative when I hear, well, why do I need all of these, and what should I expect? And I think that's a great question, because those two questions tell me that, number one, that you're more likely going to take it, and number two, you're going to be aware of what the potential problems are, so that we can work together to get past them. Because many side effects, oftentimes it's the first incidence of the side effect that patients stop taking the meds, and then it becomes this unspoken sort of hill that we can't get over. And oftentimes, for example, with statins, we've realized many statins, if you can just push through and really start at lower doses, the muscle aches and the fatigues often go away. And so, that dialogue early on would really help us to make sure that we give you the most information. We can even hook you up with pharmacists if that's available in the area. So really asking those questions: why do I need these medications, and what should I expect to get from them? And definitely, I think in our communities, I think advocacy is the one thing that I really see, that I wish, even if you don't know how to advocate for yourself, and it's fine. I mean, you don't have to be the person, but having people with you, if you really feel that you're not going to be comfortable asking those questions, but having someone who will ask those questions for you. I mean, that is one of the critical things that I've seen such difference amongst communities. And I really try to make sure that, if I don't hear those questions, I try to provide it for the patients. So those are the two other things that I would ask.
Dr. G, bring us home.
For me, it's real simple. I would employ folks to ask their physicians, who do you see when you see me? And the reason I say this is, a lot of times when we go into appointments, we're already nervous. We already think that we're going to hear the worst. But in my experience, to be shamed and to presume that everything is my fault and that I harm myself intentionally destroys the humanity of the person that you want to treat, and to help them manage their particular disease state. When you think about kidney disease, this is probably one of the most invisible diseases there are, that is currently killing people in Black and brown communities. Folks don't know anything about this because it's not a casual conversation that some of us, depending on what generation you grew up in, your family didn't discuss any type of medical challenges. So if you aren't getting a genetic test, sometimes you just happen to fall into a particular disease state, such as myself. So I would just encourage folks to really not only speak up for the information that you should know, but to also speak up for the respect that you deserve as a consumer, as a patient, as somebody that's expecting to receive the best treatment possible. Because a lot of times, I have had to deal with some really egregious situations that almost made me give up if I didn't have somebody to kind of be there to encourage me. Hey, man, they knocked you down, get right back up and go right back in there, because you are worth that fight and you're fighting for your life and your health. So that would be what I would certainly suggest.
Well, I am deeply humbled by the presence on this panel and their expertise. And I want to thank each of them for sharing their insights and lived experiences with us
Absolutely.
tonight. I don't see any questions in our chat, but we have a few more minutes. If somebody either wants to, I believe I'll ask our administrator if they can raise their hands and open the mics, or if it all has to go through the chat.
Yeah, and I'll jump in here now while we're transitioning. And again, just to say thank you to MedTech Color, Dr. Sparks, Dr. G, of course, Dr. Theodore, Dr. Matthew, for your time, your concern for our community, and your willingness to share. Again, I echo you, Dr. Sparks, that the panel shared from a place of care and concern, and we're more the better for it. I didn't have much to say. It was no need for me to say anything. You all are the experts for sure. But what I will say is the persons that will receive this information, I know they will they'll take it, they'll use it, they'll apply it, and they will advocate even the more for themselves. That's something, so when you talk about the Know Your Numbers, that's something that we do, a men's event, a woman's event, just because the information's a little different. But we are always giving the participants tools that they can, when they go to see their healthcare provider, that they would go prepared. And again, this type of information helps us to be better prepared, to care for ourselves, to advocate for ourselves. So thank you again.
And thank you, Reverend Miles. So let's, top line it. Know your numbers. Let's get that down. Know your numbers. Have courage. Ask the question, why is this important for me? And what should I expect to happen once we engage here? And two, look outside maybe of your network to some of the larger organizations to go and get a deeper understanding of this disease state. So tonight, the goal of today and tonight's conversation was not only to share what clinicians and scientists are seeing, but also to empower you, those that engaged with us, the patients, especially in communities that often experience disparities, to be active participants in your care. And now that more people are hearing the term cardiometabolic health, you will have information about what questions you should bring to your doctor or to your advanced practice provider, nurse practitioner, or PA, or even your pharmacist about this disorder. And finally, I want to thank you, the audience, and give thanks to Enon Tabernacle Baptist Church for their collaboration in this webinar, our panelists for their insights and, again, lived experiences, and to all of you for engaging with us. Together, we can reimagine cardiometabolic health with equity at the center. So I wish you all a good evening, and thank you for joining us.
Thank you, Dr. Sparks.
Dr. Sparks. Thank you.
Thank you. Okay, we had two comments, and they were just to thank us and then thank you so much. And they said it was very helpful. So that's important. That was our goal.
Absolutely.
Very good. It was wonderful. I was over here listening myself.
Absolutely. Always learning, always learning.
All right.
Now, this will land where? How can we see this again? What are we doing with this webinar?
So it is being recorded, and it'll land on our website eventually, and I believe our YouTube channel. So we will share the link so that it can be accessible to whomever would like to use it.
Absolutely.
All right. I was going to thank everybody again. Dr. Theodore had to run, but thank you. And Dr. Matthew, I guess already, when I said good night, they were like, good night, peace out. So